Good morning, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute. I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you doing?
Doing quite well, thank you.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, or public health questions each week here on the Havey Institute's Facebook page. Today, Dr. Murphy will be addressing the latest headlines and U.S. statistics through today, April 4th. We invite you to submit any questions you have down below via our Facebook, NU Institute for Global Health, or by email at globalhealthinstitute@northwestern.edu. Getting into the newest U.S. COVID statistics. Average new hospitalizations per day, 1,550. The same week in 2023, we saw 2,595 hospitalizations. Average COVID deaths per day, 108. 2023, 252. New vaccine uptake for adults, 22.6%, those 65 plus, 42.1%, and 14.1% in children. Your reactions to those numbers, Dr. Murphy?
Well, they continue to trend downward as predicted. We're now in April, and April should be the end of the respiratory illness peaks that happen that start typically in December. So we would expect these numbers to continue to drop. Although the weather is not cooperating with us lately here in Chicago. We had snow yesterday, but it's going in the right direction. The death rate now is just a little bit over 100 per day. I mean, these people, otherwise, this is dying from COVID. I mean, if COVID didn't exist, these 100 people would be alive. So it's still too high. That's, it still puts it, over 36,000 cases per year. That's a lot on top of everything else. So, but it's going in the right direction, and we expect continued improvement.
Mm-hmm. Now, we usually start out with COVID stories, but there was a massive public health announcement this week regarding the avian flu and human infection. Can you please break that down for us and tell us a little bit more about the avian flu in general?
Right. Remember, there's all kinds of flu. Different animals get kinds of flu. Sometimes some flus are better for humans, some are for animals. There's all sorts of influenza out there. So H5N1 is the avian flu. It's really devastating in birds. And it's one of the reasons why chicken and egg prices are going up. Because once it's identified in a poultry population, they typically have to cull the entire group of chickens or whatever animal has got it. And since the outbreak onset, this started in 2022, the U.S. Department of Agriculture has paid over $500 million to cull infected flocks. I've been watching just the regular news where this stuff is popping up. It's just devastating. Many of the commercial chicken processing places and chicken farmers, and it's really quite devastating. And thing is, if they don't do that, the mortality rate in the birds is really high. I mean, if you see a dead bird now out there, it probably they had avian flu, and you want to stay away from that bird. Call the health department to have it removed. You don't want to go near them because they could be contagious to you. So up until now, we haven't seen much. It's been really rare to have avian flu in humans. With about over half of the infected animals dying. I mean, this is a really lethal thing in birds. So, but in humans, they're nervous. Is this thing going to mutate when it gets in a human? And is it going to have a higher mortality rate than the other influenzas that affect humans? We don't know. But we have the second case now in a human recently, and most likely these people did get it from an infected animal. either a cow or bird. So cows get it too, and they're typically older cows, and they're getting ill. So now they have to look in cows. So other animals can get avian flu too. So it's really kind of a huge, Pandora's box here in what's going on. We don't really know what's happening. It's not a crisis at the present time. Two people have gotten sick, but so far there's still no human to human transmission that we know of, and the 2 people that have gotten infected are doing okay. But this is something that has to be watched very closely, and that's going to require the culling or the killing of infected flocks and maybe herds of other animals.
Yes, very distressing to hear. One thing I was seeing a little bit about with this story was a change. They were wondering if there was cow to cow transmission versus bird to cow, human to cow, a lot of different factors there. What are the kind of more dangerous things or cautionary signs that we see in terms of those different transmission types?
Well, this really has to be studied, and if there's anybody suspect, any animal suspect, they need to be tested right away, because we really don't know how much is out there, especially in non-bird populations. The bird people, the people that are commercial bird farmers, are they're on top of this. But other animals that could be infected, they're not necessarily looking for it, and animals get sick, and but now we have to be much more vigilant, and also people get sick. So right now we just have to be aware if someone is in contact, especially with sick animals, either birds or cows, you have to think of bird flu, and your health department can help you with the testing.
Yeah, this is a story that we will be continuing to research and keep up on all of the newest information and report it to you. But getting back into our COVID subject, there was some newly released data surrounding the spring COVID booster in certain people. Could you tell us about that data?
Yeah, so it's more about vaccines in people who are really at high risk is what we're talking about here. So people who have really weakened immune systems. And they looked at these more recent booster shots that are recommended now. And they found that in a very large study with over 14,000 participants, including 1,392 who ended up in the hospital, that severe COVID was cut by a third in these people with really weak immune systems if they had been vaccinated. So it's just more data on top of other data that shows if you're really sick, you can cut this hospitalization rate, which cuts the death rate. I mean, you just don't die from COVID. You end up in the hospital first, and then you're going to die if you're going to die from the disease. Remember, this is a potentially fatal disease. And if you have it's good to know that even people with the weakened immune systems, that you are having a significant effect from the vaccine booster. So please keep up with the boosters. So the booster is recommended right now. This is with the current vaccine that came out last year. In the spring, in the fall of this year, there will be a new vaccine. So that will be recommended as well. So some people are waiting till then if they're all up to date, if they've got a weak immune system or at risk, or if they just want it, they can take it now, the current one, and then take the new one in the fall. Take it with the flu shot if you want. And we talked about this last week, but there's some evidence that if you take the flu shot and the COVID vaccine on the same day, you actually have a better COVID response. That was a nice little study that was done. But anyway, so this is encouraging news, especially people who have underlying medical problems.
And for those patients who are most at risk, perhaps they physically cannot take that vaccine, or their own antibody response is not as strong because of an immunocompromising condition they have. There was a new announcement that an EUA has been granted for a COVID pre-exposure prophylactic. Can you tell us a little bit about this drug?
Yeah, so this was just authorized by the FDA. The drug is called Pemgarda. It's made by a company in Massachusetts, Invivid. And it's a neutralizing antibody that's very effective in for preventing COVID happening. So we had these monoclonal antibodies in the past. This is actually a stronger type of antibody, and it showed that it helps these people, and it had a very high rate of preventing new infections. But the problem is with these kind of this type of antibody production can only be given intravenously. So you have to take an infusion. It's pretty safe. It doesn't have a lot of side effects associated with it. And you can repeat the dose every 3 months. So who is going to take this? All right. You got to go to all the trouble to have the IV and whatever. However, if say you have some underlying immune deficiency, you have a cancer, you have some reason why you are not mounting an immunologic response, a good immunologic response, and you don't want to even get COVID. Now you could get treated after you get it, but a lot of those people still don't make it. So in these high risk people, you can take this. Like if you're going to travel, you're going to go someplace or whatever, take this antibody. Because it will protect you when you are surrounded by other people who could have COVID. Now, the COVID numbers have gone down. Flu is still kind of high, but COVID has gone down. But, we're expecting other peaks of this. And so depending on your travel schedule, the kind of people that you're surrounded by, you're going to a place with a low vaccine uptake. Many places, a lot of people are not taking any of these vaccines. You want to protect yourself, you can take a treatment like this and you can just repeat the treatment. Now, I have a few patients who've had bad side effects from the vaccine, or they're allergic to some of the vaccine components. It's not very common, but it does exist. Those people would be really good candidates to prevent infection. Prevention of infection is always better than treating infection.
Mm-hmm. And can you tell us who this drug was approved for? Is it for, everyone 6 months and older, like some of the other vaccines, or is there a more limited set?
No, it's really for severely immunocompromised patients. It's not for everybody. It's
Okay.
These people know who they are, and their doctors should be recommending this. And this would be, like I said, people who've got underlying cancers or some immunologically suppressing disease that's limiting their ability to make the antibody to the vaccine. This is the antibody. They're just loading the body up with this.
Okay. Switching gears a little bit, something that we have been talking about over the past few months is tuberculosis in the United States and globally. There are reports that we had the greatest climbs in our US TB levels for many years. Can you break that down for us?
Yeah, the TB cases in 2023 were the highest in the last decade. So it's popping up. 40 states of the 50 reported increases in TB last year. In many of the age groups, most of them were in people who had what we call latent TB. In other words, they had been exposed to TB, but they didn't get clinically sick. So they had it in their body. And then they got sick and their immune system got compromised and the TB came back. That's called latent TB. Latent TB converting into full-blown tuberculosis. And it's estimated that like 13 million people in the United States have latent TB, including myself. I got exposed when I was a medical student. And so my test for TB, there's a blood test for it and there's a skin test for it, they're positive. I mean, if something happened to me immunologically, it could come back. I never felt sick, but this is not an uncommon feature. So there's a lot of these, and this corresponds with worldwide what's going on. There's a surge of tuberculosis worldwide. The immune system is weakened. It puts people, like I said, much more at risk. People with HIV who untreated very, very high risk of tuberculosis. It's how are they going to deal with this? Well, they've been working on a vaccine for a long time. That continues. But they've got to identify these people earlier and treat them. So that involves good public health. Getting more caseworkers to track people down, test people if you're suspect. It's basic good public health medicine. And that's the only thing we really have. Now, still, this isn't a crisis like it was in the late 19th century, or even earlier in the 20th century. In the late 1800s, TB actually killed 1 out of every 7 people in the United States. It was a very, very common cause of death. And of course, that's all changed because we have the treatment, and in some populations, there's even a prevention you can give, a vaccine you can give. But we just have to keep our eyes open and keep looking for cases and treating them early and isolating them, because of course these people are contagious to other people. And we need to keep working scientifically on getting a vaccine developed that will prevent people from getting this really life-threatening, very serious disease.
Yes, and as you mentioned, 1 in 7 Americans, that's a lot of people back in the 1800s. Don't want to catastrophize and say that's what's happening now. Clearly, a huge public health effort has gone into curbing tuberculosis, and something that we need to keep up with.
Yep.
Similar story for a different disease. Mpox has been also rising at a bit of an alarming rate here in the US. Can you break that down for us as well?
So monkeypox is now called Mpox. So we get the monkey out of there. This is an Mpox. So it's related to smallpox, but it's not smallpox. And there was this little epidemic, not little, actually it's quite a big epidemic that occurred. And people can transmit it to each other. And it's been very high risk for men who have sex with other men, just in the contact. But I mean, you don't have to, a man can give it to a woman, or a woman to a man, or a kid to whatever. It is a contact transmission. So the cases in the last year have doubled. Now this is a disease. It's relatively, it's a re-emerging disease that has left the animal to man transmission that we saw in some parts of the tropical world. And now it can be person to person. There's a vaccine for this called the Jynneos vaccine, manufactured by Bavarian Nordic. It's recommended for people at high risk who are 18 and older. And the uptake of this vaccine, which is very effective, is about a quarter of the high-risk people have taken it. So we've really got to work on getting the coverage up in the highest risk group. Now, there's some evidence that if you've had a smallpox vaccine, that maybe you would be immune yourself. That really, I guess, remains to be seen. But you would have some protection if you had this smallpox vaccine, but that was stopped a long time ago. But anyway, it's just another disease that's out there that can be prevented by a vaccine that's very easy to administer. You do need 2 doses of. We need to be vigilant here too, especially in the high-risk populations.
And is that vaccine something like the COVID vaccine where you would need to get boosted, or is it a long-lasting vaccine?
No, it's long-lasting, but you need the 2 initial shots. The one kind of protects you grossly, but the second one really jacks up the response significantly, like in measles.
Now, our final story for today is a little bit of a nomenclature story. We have talked about Alaska pox as it emerged in the past few months. on my radar at least. It's been there, but there's now a new name for this virus. Can you tell us a little bit about it and why they changed the name?
Yeah, so Alaska pox was first identified in humans in 2015. It's just really a handful of cases, but some of them died. Matter of fact, most of them. We don't know if that's just the tip of the iceberg or whatever, but all the cases were up and around Fairbanks, Alaska, or close by. And it was just called Alaska pox because nobody saw it anywhere else. Well, I'm sure it's in other places, and we really have to be careful about naming things geographically because this could pop up anywhere, and people won't think about it if it's just, if they say Alaska pox, they think, oh, you have to be from Alaska. You don't have to be from Alaska. So it's called boreal pox. So it just name changed. It's just one of those improvements in the terminology, like monkeypox to Mpox, and it's just the same kind of thing. They're just changing the name of it, but I just thought it was an unusual story that came out, and I think it's a good idea that they did that because I'm sure there's more of this than just in Alaska.
Absolutely. Viruses and diseases do not much care for our artificial borders on maps. They do their own thing. But on that note, Dr. Murphy, thank you very, very much for breaking down all of these stories, for sharing your expertise. As always, much appreciated.
All right. Thank you, Katie.
And thank you all for joining us for another episode of Ask Dr. Murphy. As always, please feel free to leave any questions you have down below or contact us through any of our social medias in the description. Thank you again and have a lovely weekend.
You too.